Okay, so good morning, everybody. I'm just going to start off by going over some just some important dates and housekeeping stuff. Don't forget that your discussion question number 2 is due today. Okay, that's the one on pneumonia and respiratory acidosis. Okay, it's due today, but I'm keeping it open and I'm keeping it open until Friday. Okay, so it's not, this one is not for a grade, it's for an assignment, it's for participation. So that's due tonight at midnight. Okay. Um, let's see, your test is going to be next Tuesday on campus, February 2nd. Okay. Um, let's see, I'm just muting everybody. Okay. So that's going to be on campus. Everybody's going to be able to come on campus. Okay. I'm going to have sign in sheets. Okay. So you'll have to sign in when you come into class. Okay. To, verify your presence there. Okay. So like I said, we're going to be in room 401. That's going to be the first classroom when you come into the building. That's going to be the first classroom on your left-hand side for room 401. That's where we're going to have class. Okay. Let's see. Seeing what else I have to talk about. Okay. So I made a few mistakes yesterday in my lecture and I wanted to go over that with you guys. I said that a patient, when we were talking about pain, that a patient feels pain in the modulation phase, and that's actually not true. Okay. The patient actually starts feeling the pain in the perception phase. Okay. So I wanted to clarify that from yesterday. A patient actually, a patient actually starts feeling pain in the perception phase. So wanted to clarify that. I looked into the discussion. Somebody had asked yesterday, I can't remember, I apologize. But somebody had asked about arthritis being nociceptive pain or neuropathic pain. And I looked a little bit more into that. And because it's coming from the joints, like I thought yesterday, okay, the joints are like a visceral or the joints are actually a somatic thing. Okay. So because it's a somatic thing, it's going to be a nociceptive type pain, more along the lines of neuropathic. Okay. So I just wanted to clarify those two things. Does anybody have any questions? Robin saying she's got internet problems. Okay. Yeah, it's crappy weather today, so I'm expecting people to go in and out. It's okay today.
I did want to clarify something about the clinical uniforms. I just want to make sure I remember correctly. You said we don't need the embroidery this semester. We just need
That's correct.
Okay.
That's correct. You guys are grandfathered in. You do not need the embroidery. You just need the patch on your left-hand side of your scrub top. You do not need it on your jacket. I talked to Miss Lott and I clarified that. So you just need the patch on your left hand, your left arm. No embroidery.
Okay, thank you.
You're welcome. Any other questions? So I'm going to just kind of give y'all the outline for today's class. Okay. So we're going to, after this, we're going to do an acid-base Kahoot. Okay. To see what you guys remembered about acid-base. Okay. We're going to have a few ABG problems on there so you guys can practice. Okay. We're going to take we're going to take a break after the Kahoot. Then we're going to finish the PowerPoint on pain. Okay. And then once we finish the PowerPoint on pain, I'm going to do a Kahoot on pain to see what you remember. Okay. And then after that, we're going to play a cool game. It's called Build a Patient. Okay. I'm going to split you up into groups and you guys are going to build a patient. based on pain, okay, based on a patient that comes in with pain. One group is going to be an assessment group, one group is going to be a goal and planning group, one group is going to be in an implementation group, and one group is going to be a eval group, an evaluation group. Okay, so it's just kind of fun to build upon what the other group has done before. So it's worked in a few of my classes. So we'll see if it works for you guys. And it helps you to learn, you know, the nursing process better with the patient with pain. Okay, Emily Watson says, since we have clinical tomorrow, are we still going to have lecture as well as the ATI assignments for clinical? No. No lecture tomorrow. You would just be doing the ATI assignments tomorrow. And I'll be discussing that more later on in class. I have instructions on how to get to them, what you have to do to get credit for them, and everything. Okay. Okay. So, yeah, so we're going to do the build a patient. All right. And then after we do the build a patient, I'm going to go over the clinical stuff for tomorrow. So no lecture tomorrow or Friday. You'll just have the ATI virtual clinical stuff to do. Any questions? Okay. All right. So I'm going to go and get into my Kahoot. So if everybody can log on to Kahoot real quick. Excuse me. Okay, let's see. And if anybody came in after 8 o'clock, if you guys can just type in the chat if you haven't already done so that you're here. Okay, let's see. So this is acid base. Okay. So let me share my screen first. Share sound. Kahoot. Okay. All right. See what we got. You can either log on to the Kahoot website or you can play through the app. Okay, it's up to you, whichever one is easier for you to do. Okay, classic. Can everybody see this screen that says get ready to join? It's still loading the game pin.
Yeah, I can see it.
Okay. The game pin, in case you guys, some of you, I know some of you are on the phone or whatever, it's 431-5265. Okay, if you can log on, don't log in if you're driving. Zoe, I know you're going to an appointment, so don't log in if you're driving. Ooh, okay, let's see. Okay, I'm gonna give everybody about 30 more seconds. to log on. Game pin is 4315265. Okay, I'm gonna go ahead and get started here, okay?
Miss Adams,
Yes,
this is Tamika. I'm trying to log in with my phone. I can't, my computer is slow, but I'm following along. I am so sorry.
that's okay, just follow along, okay? So what is the normal pH for blood plasma? Normal pH. Okay, very good. 7.35, okay, is the normal. It's 7.35 to 7.45, but you didn't have 7.45 in your choices. So the only choice here was 7.35. Very good. Know that pH range, okay? Know it, know it, know it. 7.35 to 7.45, okay? Okay. Okay. What medical condition would contribute to respiratory alkalosis? Okay. Respiratory alkalosis. Okay. Remember, respiratory, the lungs are in trouble. Okay. And alkalosis is either too much base or not enough acid, not enough CO2. Respiratory, lungs are in trouble, alkalosis, not enough CO2. Okay, anxiety. In respiratory alkalosis, remember when people are anxious, a lot of times they hyperventilate, they okay, so they're breathing off CO2 too fast. They're not retaining the CO2, okay? So that's why it would put them in respiratory alkalosis, okay? Some of you said COPD. COPD would be more along, COPD would be when they're retaining too much CO2, okay? That's what COP would be, COPD, okay? But remember, anxiety, you hyperventilate, you're breathing off too much CO2, you're losing too much CO2, you're in alkalosis. You don't have enough CO2, okay? Any questions there? Okay, all right. All right, Zoe's in the lead. Okay, what imbalance happens when the pH is low and the CO2 is high? Low pH, below 7.35, PCO2, the carbon dioxide is too high, over 45. So we know we can cancel two of them out. Okay, respiratory acidosis. Okay, correct. Okay, so respiratory, okay, so the pH, we know it's acidosis because the pH is low. It's below 7.35. And we know it's respiratory, okay, because they're going in the opposite direction. The pH is going low and the PCO2 is going high. They're going in the opposite direction. You remember Rome, respiratory, opposite, metabolic, equal. Okay, so that's how you know it's respiratory acidosis. Okay, all right. All right, let's see. Opal said my screen didn't move on the game. Okay. You may have to log back in and off, Opal. I'm not sure why it's doing that. Okay, let's see. What issue would result in metabolic alkalosis? Okay, so metabolic alkalosis, kidneys are in trouble, too much base. Too much bicarbonate. Okay, very good. Mostly everybody got that right. Overuse of antacids. Okay, antacids have a high bicarbonate content in them. Okay, so if they overused antacids, they would have too much bicarb in them and they would be in alkalosis. Okay, very good. Very good. Okay, Bridget's in the lead. Okay. What is pH? What is a high pH and a high bicarbonate? pH is above 7.5. Bicarbonate is above 26. Would it be respiratory alkalosis, respiratory acidosis, metabolic acidosis, or metabolic alkalosis? Okay. It would be metabolic alkalosis. Okay, we're going to look at the pH first. It's telling us that the pH is high. It's above 7.45. Okay, so it would be alkalosis because the pH is high. So we know it's either respiratory or metabolic. Okay, what direction is the abnormal lab going in? pH is going high. So is the bicarb. It's going in the equal direction. Okay, according to Rome, R-O-M-E, if your pH and your abnormal lab is going in the same or equal direction, it would be metabolic. Okay, metabolic equal. Okay, very good. Y'all are getting these. Good. Okay. What is respiratory acidosis? A bicarbonate deficit, an excess of bicarbonate, an excess of CO2, or a CO2 deficit? Respiratory acidosis. Okay, it's going to be an excess of CO2. Okay, and respiratory acidosis, respiratory equals CO2. Okay, I always think respiratory equals CO2. Okay, so you're going to either have an excess of CO2 or a CO2 deficit, but it's saying you're acidotic. It's respiratory acidotic. Okay, so you're going to have too much CO2 when you're in respiratory acidosis. Okay, you're going to be acidotic. Your CO2 is going to be high. Okay, it's going to be above 35. So you're going to have too much CO2 on board in respiratory acidosis. Okay, if you would have a CO2 deficit, if you wouldn't have a lot, if your CO2 would be low, okay, if you wouldn't have enough, okay, you would be alkalotic. You would be in respiratory alkalosis. But in excess of CO2, you're in respiratory acidosis. Okay. All right. So I always think respiratory equals CO2, metabolic equals bicarb or HCO3. Okay. I'll try to get those relationships, okay, in your head so you can remember them. What is respiratory alkalosis? We just went over. Is it a bicarbonate deficit, an excess of bicarb, an excess of CO2, or CO2 deficit? Respiratory alkalosis. Okay, very good. CO2 deficit. Everybody got that right. Very good. Okay. All right. Bridget's in the lead. Okay. Metabolic acidosis can be a result of what? Hypoxia, diarrhea, or potassium deficit. So metabolic acidosis. Metabolic is the kidneys are in trouble, okay? And acidosis, your pH is too low. Okay, your pH is hot. It's going to be below 7.35. Okay, so diarrhea, okay, is going to be your cause of metabolic acidosis. Okay, because you're losing. You want to think diarrhea. Okay, you're losing acid in the diarrhea. Okay, wait, no, that's not right. Hold on. Think about this. I got tripped up on this yesterday. Metabolic is the kidneys. Okay. Acidosis, your pH is too high. Okay. So it's more that you're losing bicarbonate and the diarrhea. So your acid is going to be high. Okay. So that's what this is. That's why diarrhea causes metabolic acidosis, because you're losing too much bicarb in your diarrhea. So your acid's going to be high. If you're losing bicarb, acid's going to be high. Any questions there? I know that kind of got a little confusing.
So are you saying that the pH is going to be high?
No, pH is going to be low in
Okay.
acidosis.
Yeah, okay, that's what I thought it was.
Yeah, pH is going to be low.
Okay.
It's going to be below 7.35 in metabolic acidosis. Okay. But your bicarb in diarrhea, because it's metabolic, okay, so remember, we think metabolic, we think bicarb, okay? So your metabolic, if it's acidosis, okay, you're going to be losing bicarb, okay, because you're going to be in diarrhea, you're losing the bicarb, so you'll be retaining acid, okay? So you'll be in acidosis. Okay, it's a bicarb issue because it's metabolic. So you think metabolic, bicarb, respiratory, CO2. Okay. All right, let's see. Okay. Aaron's in the lead. Okay. What happens when the pH is low and the bicarb is low? pH is low and the bicarb is low. pH is below 7.35, bicarb is below 22. Okay, very good. Metabolic acidosis. They're both going in the equal or same direction. The pH is going down and the HCO3 is going down. They're both going in equal directions. Okay, so it would be metabolic and the pH is low. It's below 7.3. So it would be acidosis, metabolic acidosis. Okay. Okay. Let's see. Okay, Aaron's in the lead. Last question. Which of the following is a compensating respiratory mechanism for metabolic acidosis? COPD, Kussmaul's respiration, asthma, or pulmonary embolism? Compensating respiratory mechanism for metabolic acidosis. Okay, very good. Kussmaul's respirations. Okay, because remember, in metabolic acidosis, kidneys are in trouble. Okay, the kidneys are in trouble in metabolic acidosis. So the lungs are going to come to the rescue. However, in acidosis, okay, you're retaining too much CO2. Okay, you have too much CO2. Okay, so you need to expel that CO2. Okay, to balance out your bicarb. Okay, so the lungs are going to come into the rescue because the kidneys are in trouble, and it's going to tell the body, okay, you need to start breathing off the CO2. Kussmaul's respirations. Okay, so always remember that Kussmaul's respirations is a compensating respiratory mechanism for metabolic acidosis. Okay. Always remember, when kidneys are in trouble, you're going to have a respiratory symptom that's going to try to compensate. Okay. When the lungs are in trouble, the kidneys will come in and rescue and give you some kind of kidney type symptom like diarrhea, vomiting, or any kind of other, anything other than respiratory. Okay. Yeah. So increased urination, vomiting, diarrhea, it might even, it's a mild one, but maybe blood pressure. Okay. Maybe a compensating kidney mechanism for when the lungs are in trouble. Okay. But most of all, it's going to be something either GI related, or they're going to tell them it's going to be a urine related compensating mechanism. That makes sense? Okay. So you think about when you see the condition, you think about which organ is in trouble. Okay. So in here we say the kidneys are in trouble. Okay. The kidneys are in trouble. So the lungs are going to come to the rescue. Okay. So look at your answers. You're going to look at all your different answers and you're going to say which one is related to the lungs. Well, technically they're all related to the lungs. Okay. So we stop that. Okay. So we're like, okay, well, which one is, because the patient is in acidosis. What does acidosis mean? Acidosis means they have too much CO2. They're holding on to CO2. So we need to get that bicarb up, or we need to get rid of the CO2. How are we going to do that? Okay, we're not going to do that in COPD. Okay, well, first of all, COPD is not a mechanism. It's a disease. Okay, so it won't work at all. Asthma, same thing. It's a disease. Both of these are going to hold on to the CO2 ions. They're going to hold on to CO2. Okay, so they're going to make the CO2 higher. We don't want to make the CO2 higher because we're in acidosis. We want to make that CO2 lower. So the body's going to say, you need to breathe it off. Okay. You need to breathe fast. Kussmaul's respirations. Okay. So look at what it's asking. Look at the condition in the question and break it down. What organ is in trouble? And what is the body going to do to compensate for it? Okay. Any questions? Okay. Okay. All right. So let's see who won. Cheyenne. Cheyenne came out third. Good job. Bridget came out second. Good job, Bridget. And Erin came out first. Good job, Erin. All right. We have Zoe and Mackenzie that came in as runners up. Y'all did really, really well. Good job. Good job on this Kahoot. Y'all remembered a lot. Okay. So just like I said, just take that condition, whatever the question is showing you, and break it down like I told you. What organ is in trouble? And what's going to be the compensating mechanism of the organ that's going to come and rescue it? Are they going to tell them to breathe faster, breathe slower? Are they going to tell them to pee it out or hold their pee? Are they going to tell them to poo it out? Okay. Or are they going to tell them to hold on to it? Okay. So again, metabolic versus respiratory. Okay. All right. Let's see. Okay. I want to see. Hold on, guys. I'm going to look here. I want to see if I have any problems here. Hold on. Oh, Kahoots. Let's see. I want to do a few Kahoots. A few problems. Let's see. Hold on. I think I had some. Nope. Sorry guys, hang on one second. Hang with me. You know what? I know what I'll do. Hold on. I was muted. Sorry. I'll be right back. I'm going to grab something real quick. I'll be back in 1 minute. Okay, guys, I'm back. We're gonna do a few acid-base problems for a few minutes, okay, and kind of practice those. Okay, so I'm going to, let's see, do a whiteboard. Okay, so I'm gonna share my screen and do a whiteboard. Okay. Okay, so I'm gonna give you guys, okay, about 30 seconds, okay, to figure out this problem, okay? And I'm gonna need you to type it in the chat, okay? Or, yeah, go ahead and type it in the chat. Don't say it out loud, just type it in the chat what the answer is, okay? All right, so we're gonna do a few problems so you guys can practice, okay? All right, so let's see. So here's your pH. 7 point. Oops. And CHCO3. Okay. All right. Okay, so I'm going to give you guys 30 seconds. Well, mostly everybody's doing it already. And then we're going to work it out together. Okay, I'm going to give everybody about a couple more seconds. Okay, so everybody said respiratory alkalosis. However, I'm going to be a little bit evil here, and I'm going to call on Miss Erin Terrebonne to tell me how she figured out that it was respiratory alkalosis. Erin? Okay, Erin said she'll type it. Erin, can you turn your camera on? Let's see what she came up with. Okay. You're still typing, Erin? If you're muted, make sure you're unmuted. Okay, she says the pH is high and you would use the CO2 since it's low. Okay, so she's correct. Okay, the pH is high. Okay, so I'm going to draw. Okay, so the pH is high. Okay, and she said the CO2. Okay, that's okay. She said the CO2 is low. Okay, so the CO2 is the abnormal lab here, okay? So if you're using the Rome method, okay, R-O-M-E, okay, it's going in the opposite direction, so respiratory opposite, so respiratory alkalosis, okay? And Marissa said the bicarb is within normal limits, right? Yes, that's correct, okay? You're always going to be focusing on either which lab, either the bicarb or either the bicarb or the carbon dioxide, which one is going to be abnormal. Okay. And that's the one you're going to focus on. Okay. Because if one's abnormal, okay, 9 times out of 10, the other one is going to be normal because why? Because it's coming to the rescue, okay? So the kidneys here are coming to the rescue. So they're gonna normalize, they're gonna try to normalize everything, okay? So the bicarb is going to be normal because it's coming to the rescue because the lungs are in trouble, okay? Very good, good job, Erin, okay? Let's see, clear all drawings. Okay, so we're gonna do another one. pH. Oh, wait, hold on. I want to erase that. Hold on, clear. Hold on, I'm going to text it. I'm a terrible draw. Okay, so we're going to say the pH is 7.23. The CO2 is 37. And the HCO3 is 18. Oops. Okay, so tell me what you guys think it is in the chat. Meta-acidosis. I'll give you guys a few more seconds to solve it out. Okay, so mostly everybody is saying metabolic acidosis. Okay, so let's see something for a second. On here. All right. Okay, Opal, tell me why you chose metabolic acidosis.
I chose it because the pH is low. So
Okay.
that's telling me that we're dealing with the kidneys,
Mhm.
and the HCO3 is low as well. So it means both of them will be the same as far as that. And the lungs is trying to compensate to help the kidneys out. So that's my answer.
Cool. Very good. Okay, very good. So metabolic is the same. Okay, so same or equal. Okay. Very good. They're going in the same direction. Okay. So it would be same would be metabolic. So and the pH is low. So it would be metabolic acidosis. Very good, Opal. Good job. Okay. All right. We'll do another one. Okay. All righty. Let's see. Okay. Let's see. It's gonna be a little tricky text. Okay. So pH is 7.30. CO2 is 36. And H would be 16. Okay, tell me what you think. Respiratory acidosis, respiratory acidosis, respiratory acidosis. Okay. Metabolic acidosis, metabolic acidosis. Okay. Okay. Metabolic acidosis. Emily's saying respiratory acidosis and metabolic acidosis. She's saying same. Okay. All right. Okay, Emily, tell me what you think it is. Emily Watson, tell me what you think it is.
Well, at first I thought it was respiratory acidosis because the pH is below 735
Okay.
and the carbon dioxide is 36, but the normal range is 35 to 45. Oh wait, nope,
Correct.
it's normal. That's normal. So it's actually metabolic acidosis. I,
Yep.
for some reason, thought it was below it. I don't know. I must got my
Yeah.
numbers mixed up.
Just, yeah, always remember those numbers, okay? All right. Always remember your normal numbers, okay? Because this was a little tricky one, okay? Because I kind of said, okay, well, it's close to abnormal, but it's the CO2 is still in normal range, okay? So it's still within normal range. Whoops. Okay, so it's, oh shoot, hang on, eraser. Okay, so this is still normal, okay? Normal.
Miss Adams.
Yeah,
So could you have both?
what do you mean?
Like, could a person actually have like metabolic acidosis and respiratory acidosis, or like
No.
the opposite?
No, you can either have one or the other.
Okay, I was
So
just curious.
yeah, so that your pH is low. Okay, let's break it down. Your pH is low, so we know it's going to be acidosis. Okay, so we know it's going to be something acidosis. Blank, 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 acidosis. Okay, so your abnormal here. Okay, your abnormal is your bicarb. Okay, this is your abnormal. Okay, so this is low. Your bicarb is low because your bicarb is normally 22 to 26. Okay, so your bicarb is low. Okay, so you're going in the same direction. Okay, so what's the same direction? Okay, so whoops, wrong. Okay, metabolic equal, okay. So it's gonna be metabolic. So because it's going, your pH is low and your HCO3 is low, it's going in the same direction. So it's going to be metabolic acidosis. Metabolic, okay. Those are the two things that when you're looking at problems, okay, you need to look first at your pH. You need to see where your pH is going. Is it acidotic or is it alkalotic? Okay. And you're going to put an arrow. It's going down. Okay. So it's acidotic. Okay. Then you're going to look at your two other values. Which one is abnormal? Okay. Which one is out of whack? Your bicarb is abnormal. Okay. So we know the bicarb is abnormal. Which way is that bicarb going? Is it low or is it high? It's going low. So we put a arrow going down. Okay. Okay. And then we compare it to the pH. What direction is it going in relation to the pH? It's going in the same or equal direction. Okay. So we go to our Rome. Okay, so because it's going in the equal direction, it's going to be metabolic. Okay, metabolic acidosis. Yeah, but you can't have, no, it's either going to be one or the other, because remember, the other organ, okay, you can't be alkalotic and acidotic at the same time. It's either going to be one or the other. Okay. Now you can change quickly from acidotic to alkalotic, okay? But you'll never be the same. You'll never be acidotic and alkalotic at the same time, okay? Because remember, it's that balance, okay? Those acids and those bases are balancing each other out, okay? That's what the body does. Did that answer your question, Emily? Emily, did you ask that question, Emily Watson?
Yes, I did.
Okay, all right.
And yeah, I did. Thank you.
Okay, I just wanted to make sure. Okay. Okay, yeah, so, okay. All righty. Okay, we're gonna do one more question. We're gonna
Miss
do one
Adams, I
more
have a
and then we're gonna
question
take a
real
break.
quick.
Yes, ma'am.
Okay, so if the pH is within normal limits, how do you figure out if it's acidosis or alkalosis?
If the pH is in normal limits,
Yeah.
they're not gonna be either one.
Okay, cool. Okay, that was my one thing that was tripping me up. Thank you.
Yeah, everything's normal. If the pH is normal, everything's beautiful, everything's in homeostasis. Okay.
Cool. Thank you.
You're welcome. Okay. All right. Let's do one more and then we'll take a break. Bridget, are we going to have to tell if it is no compensation on this test? You don't have to worry about that. Okay. Don't think into that.
Okay, but we'll have to eventually know it.
Not in LPN school. No.
Okay.
I don't think they don't have anything on the NCLEX as far as whether it's compensated, uncompensated, or partially compensated. I don't think there's anything on the NCLEX about that. Okay. All right. Okay. So we're going to do one more. Let's see. Okay. Let's see. I'm trying to think of one that I haven't done yet. Hold on. Okay. All righty. Let's see. We're gonna do a pH. Yeah. Okay, we'll do a CO2. And we'll do an HCO3 of 30. Okay. What do you think it is? pH is 7.58, CO2 of 45, HCO3 of 30. Metabolic alkalosis, metabolic metabolic alkalosis, metabolic alkalosis. Okay, let's see. Everybody another thing. Okay, Tamika, tell me why it's metabolic alkalosis.
Can you hear me?
Yep, I can hear you.
Okay, the pH is above 7.35, was
Mhm.
above 7.45.
Mm-hmm.
The CO2 is normal, and the HCO3 is above normal range.
Correct.
And so I said metabolic alkalosis.
Okay. All right. So alkalosis. So the pH is high, so it's going to be alkalosis. Okay. And they're going in which direction, Tamika?
They're going in the same direction.
Okay. So same or equal, right? So it's going to
Equal.
be metabolic if you go by Rome. Okay. Metabolic. Okay. And the CO2 is normal, so the CO2 is compensating. Okay. But you don't have to know that. All right. Okay. Any questions with acid base? With problem solving? Okay. So everybody kind of understands how to solve these ABG problems. Okay. All right. Okay. So everybody go ahead and take about a 5-minute break. Come back and we'll do the PowerPoint for pain. Okay, guys, go ahead and start logging on to, I changed my mind, actually. We're gonna do another Kahoot on what we talked about yesterday, okay? So go ahead and log on to Kahoot. Log back on to Kahoot. And the game pin is 263761. If you can't log in or something's going wrong, okay, don't worry about it. Okay, again, I'm recording. Okay, so it'll be on the recording on YouTube if you want to go back and watch it. Okay. So we're going to see what you remember from yesterday with pain. Okay.
Miss
Game pin
Adams,
is yes, ma'am.
what is this Kahoot on again?
I'm sorry?
Is this the Kahoot for pain?
Yes, ma'am.
Okay.
This is not supposed to be here. I'm taking this out. This is my calendar. Okay. Yeah, so Kahoot, the game pin is 263761. So everybody come on back onto the call if you haven't gotten here yet, okay? And log on to Kahoot. 263761. Give everybody a few more seconds. Okay, all right, we're gonna go ahead and get started. This is the pain Kahoot. Okay, this is part 1. This is what we went over yesterday. So let's see what you remember from yesterday. Start it up. What is the gate control theory of pain? Okay, when the gate is open, the pain sensation is allowed through. When the gate is closed, the pain sensation is elevated. Stimuli other than the pain stays out of the gate, or when the gate is open, the pain sensation is blocked. Gate control theory of pain. Okay. The gate control theory of pain is when the gate is open, when those pain gates are open, the pain sensation is allowed through. Okay. So we want to keep either those gates closed. Okay. Or we want to bring another stimuli on board to compete with that pain sensation so that one of them can go through the gate. Okay, so will give that pain some competition, okay? But for the most part, the basic, when the gate is open, the pain sensation is allowed through, okay? All right, very good. Okay, Angel is in the lead.
Wouldn't that be like a select all that apply and like all of those would be considered? Obviously, yeah.
I'm gonna go over it. I'm gonna go over it after. Let's see. Blank works by blocking production of substances that trigger the pain receptors. Oxycodone, Dilaudid, NSAIDs, or antibiotics. Okay, so the answer there is NSAIDs. Okay, so let's see. Aaron's like, I can't get into it. Okay. Okay, yeah, so NSAIDs are going to work by blocking production of substances that trigger the pain receptors. Okay, so NSAIDs are non-steroidal anti-inflammatory drugs. Okay, so they're going to be they're going to work in that first phase. Okay, when the pain, whatever is given the pain, okay, whatever like say, yeah, whatever is given the pain, like say you stab yourself with a knife, okay, the knife wound, okay, the knife wound is gonna automatically release some substances, okay, so NSAIDs are going to come, if you give NSAIDs when that happens, okay, they're going to block those substances that are being released. Therefore, they're going to block the ability of the pain. Okay, they're going to start early by blocking that pain. Okay. Okay, what was your last question? I'm sorry. About the select all that apply.
Oh, I was saying, like, couldn't that question been a select all apply? Because, like, I just looked at the PowerPoint thing, and it said the gate control theory, and it had 3 of the options that were listed, like, on your PowerPoint slide 7.
Okay.
But
I'll
they're all
look in,
positive.
I'll look into that.
I clicked the right one, but I was just like, I looked back at it, I was like, wait, any of those could have been except for the elevated thing.
Yeah. I'll have to go back and look at the question. Let me see. And make sure, and I'll clarify that for you. Okay, good. Let me write that down. And just to clarify. Okay. Let's see. Okay. All right. We'll look at that after this Kahoot's done, and I'll go back to that question and see. Okay. And we'll go look through it. Okay. And I'll clarify. All right. Emily Watson's in the lead. Okay. In neuropathic pain, the dysfunction of the nervous system is often caused by medical conditions such as hypertension or diabetes, or tissue damage such as trauma and surgery. In neuropathic pain, okay, it's okay, remember, in neuropathic pain, okay, it's not going to be caused by an organ or tissue, okay? In neuropathic pain, it's going to be normally caused by a condition, okay? In neuropathic pain, the dysfunction of the nervous system is often caused by the medical condition.
Miss Adams.
Yeah.
But I'm not gonna lie, that one kind of tripped me up because I know it wasn't tissue damage, but it being trauma and surgery, I felt like that would also be like why you would have neuropathic pain from trauma, like a slip disc or from like having surgery to fix it.
But would that cause neuropathic pain, or would that cause nociceptive pain in trauma when you have a slip disc?
I really don't know. I thought it would cause neuropathic pain because it'd be pressing on the nerves.
Neuropathic pain, remember, in neuropathic pain, okay, it's some kind of dysfunction of the nervous system that's causing the pain. The nervous system in general. Okay. So it would be some kind of medical condition that would be doing a number on the nervous system, that would be causing the dysfunction in the nervous system, that would be causing the neuropathic pain. Okay. Neuropathic pain equals medical condition equals nervous system. Okay. Nociceptive pain would be tissue damage, such as trauma or surgery. Okay. So nociceptive pain is going to be from tissue damage. Neuropathic pain is going to be by a medical condition that does a number on the nervous system. That's the difference. Okay. Now can nociceptive pain turn into neuropathic pain? Yes. Okay. It can turn over time. Okay. If that tissue does not get repaired, okay, then eventually it can turn into neuropathic pain. Okay. But initially, okay, when you have that initial dysfunction of the nervous system, it's going to be caused by a medical condition and it's going to be neuropathic pain. Or initially, when you have the tissue damage, such as in trauma or in surgery, okay, it's going to be nociceptive pain. Did that answer your question? Or are you still confused?
Still a little bit confused, but I kind of get where you're going. Like, I did put medical conditions because I remember you telling us that neuropathic pain is like it comes from medical conditions.
Mhm.
It's just when I seen this, like it did kind of trip me up because I thought, I thought trauma and surgery would be with a medical condition instead of hypertension.
Not
and
necessarily. Trauma can be when you get into an accident. Okay. Healthy people get into accidents all the time, right? They don't have
Yeah.
anything wrong with them, but they still have trauma. Okay. Because they had an accident. Okay. And they have now they have trauma to their system. Okay. So it's not necessarily brought on by a medical condition. Trauma is not always brought on by a medical condition, right?
Okay. Yeah.
Okay. All right. Let me know if you still are kind of foggy about that. I'll do some more research in that. Bridget put a good point. She said, think neuropathy that comes with diabetes. Correct. Okay. A person that has long-standing diabetes, okay, is going to have diabetic neuropathy a good percentage of the time. Diabetes is a medical condition. Okay. So if you kind of think of it in terms of that way, it's a little bit better. It helps to think about it a little bit more. Okay. Okay. I'll look more into that and see if I can do some more clarification on that. Okay. Any other questions there? I can see how it trips you up. Okay. But just always think trauma doesn't always have to come from a medical condition. Okay. Healthy people can have trauma all the time. Okay. All right. Next. Okay. Emily Watson's in the lead. Okay. Pieces of pain theory states the more intense the pain, the greater number of pieces, otherwise known as antiarrhythmias, antihypertensives, analgesias, and blood thinners. Pieces of pain theory states the more intense the pain, the greater number of pieces. Analgesia, very good. Okay, so that's the one that really only makes sense, first of all, okay, because none of these kind of make sense to pain, okay? So, but the pieces of pain theory states that the more intense the pain, okay, the more stuff or the more pieces you're going to need to control it, okay? In this case, the pieces relate to pain medicine, analgesia, okay? Okay. All right. Somatic nociceptive pain is body tissue, blood vessels. I have no clue. Really? Why are you asking us this? What is that? Very good. Body tissue. Okay. Somatic nociceptive pain is going to be body tissue, okay, such as joints, bones, okay. Any kind of body tissue is going to be considered, any pain with a body tissue is going to be considered somatic nociceptive pain, okay. Okay, Bridget's in the lead. What are some non-pharmacological interventions for pain? Music, biofeedback, massage imagery, or pain medicine, or pinching another part of the body, or rubbing some dirt on it? Very good, everybody got that right. Okay, music, biofeedback, massage, and imagery. Okay. I'm trying to reconnect back to the Kahoot, but it's not taking the game pin anymore. Okay. Okay, Zoe, I see you. Just follow along. Okay. And again, like I said, this is going to be recorded. So even if you're missing it for some reason, you can't get back on, it'll be recorded on the YouTube channel. Okay. All right. Let's see. Okay, if you want to try again, Zoe, the game pin is 263761. If you want to try again, I don't know if it's going to let you in, but I'm going to type it in the chat. Okay, all right. Okay, so Bridget's in the lead now. Go, Bridget. Okay. What is the first phase of nociceptive pain? Modulation, transduction, transmission, or perception? Okay, transduction. Okay, transduction is going to be that first phase of nociceptive pain. Okay, when those pain receptors get signaled. Okay, transduction. Okay, that's going to be your first phase. Okay. True or false? Treatment of nociceptive pain will be directed at only one of the phases. True or false? Treatment of nociceptive pain, okay, nociceptive pain is going to be either body tissue or organ, okay, will be directed at only one of the phases. True or false? Okay, false. That's correct. Okay. When you have nociceptive pain, okay, nociceptive pain is the tissues and the organs, okay? It's only going to be directed, it's going to be directed at, it can either be directed at one or it can be directed at all of the phases, okay, the treatment, okay, for nociceptive pain. Okay, so it can either be one or it can be all of them, okay, but it won't just be at only one, okay, because it may be one, maybe two, maybe three, or it may be all of them, okay, or it might be a combination, okay. So always remember, treatment of nociceptive pain, okay, they'll try to target as many phases as they possibly can to get the pain under control, okay. Emily Watson's in the lead. Okay, what types of conditions cause visceral nociceptive pain? Tumors or blood clots? Conditions that cause visceral nociceptive or organ nociceptive pain. Okay. So here, okay, so I know this is going to kind of trip you guys up. Okay, so conditions, when I say conditions here, I'm not really talking about a disease process. Okay, I'm talking more along the lines of a abnormality in the body. Okay, when I talk about conditions here. Okay, so an abnormality, okay, I should have said abnormality, okay? Not a medical condition, not something like a disease process like diabetes or hypertension, okay? Because that's not going to cause nociceptive pain, right? That's going to cause more neuropathic pain than it will nociceptive pain, okay? So when I say here, what types of conditions cause visceral or organ nociceptive pain, it's going to be tumors. Okay, tumors is an abnormality that is going to cause a nociceptive pain. Any questions? Okay, all right. Let's see. A high volume of pain, however, may override other stimuli and pass through the gate. True or false? True or false? Okay, good, true. Everybody got that right. Okay, so the more volume of pain stimuli that you have, the easier it will be for that pain to get through the gate, according to the gate control theory. Okay, so again, that's why you always want to give that pain some competition. Okay, you want to give that pain some competition, and that competition is in the form of the non-pharmacological measures like distraction, biofeedback, yoga, meditation. Okay, you want to give that pain some competition so that it doesn't so easily go through the gate, according to the gate control theory of pain. Okay. All right. Emily Watson's in the lead. Okay. One actually feels pain in which pain phase? This was my mistake. Perception. Very good. Everybody got that right. Perception phase is the phase in which one is actually going to feel the pain. Okay. Okay. Emily Watson. This is still in the lead. In the transmission phase, it involves movement of pain to the legs, spinal cord, brain, or stomach. In the transmission phase, very good, spinal cord. Okay, in the transmission phase, it's gonna go to the brain. I mean, in the transmission phase, the pain sensation is gonna be in the brain, but it's gonna move on down to the spinal cord in the transmission phase. Okay, so it involves movement of pain to the spinal cord, okay, from the brain, but just think spinal cord transmission phase. Okay. Emily Watson's still in the lead. Bridget's right behind her. Okay, what is an example of neuropathic pain discussed in class yesterday? What did we talk about? What kind of pain was an example of a neuropathic pain? Type your answer if you can. see what we got. Cancer, phantom pain, amputation. Okay. The correct answer, we talked about it yesterday, is phantom pain. Yes, all the other ones can be considered. Okay. Diabetic neuropathy, yes. But the one in general that we talked about yesterday is phantom pain. Okay. That is an example of a neuropathic pain. Okay. Phantom pain. Okay. Because the patient will still be having pain even though they don't have a limb there. Okay. That's phantom pain, if anybody doesn't know what that is. Okay. So it's because the neuro system is all messed up. Okay. Whatever happened did a number on the neurosystem. Now the neurosystem's freaking out and it's sending all these pain signals where something's not even there. Okay. That's an example of a neuropathic pain. Okay. All right. Let's see. Bridget's in the lead. Cheyenne's close. Which of the following would not be used to relieve neuropathic pain? Not be used to relieve neuropathic pain. Okay. Opioids would not be used, okay, to relieve neuropathic pain, okay, because it doesn't work, okay. Opioids don't work on neuropathic pain, okay, because in neuropathic pain, you don't have those transmission phases that you do in nociceptive pain. So the opioids are no good because they don't work on that. Okay, they don't work on neuropathic pain. Antidepressants can be used in conjunction, okay, with other medications, okay, for neuropathic pain, but it's only going to be used to help, not totally relieve it. Okay. All right, so opioids is not going to be used to relieve neuropathic pain. Any questions? Okay, next. Okay, you can tell if your patient is really hurting just by looking at them. True or false? Okay, false. Why is that false, Bridget Kellum? Give it a shot.
I'm not really sure. Maybe because I got that one wrong. Maybe they could be pretending. I'm not sure on that one.
It could be pretending. What did I say? What did we talk about yesterday? What is a big thing about pain? What is pain?
It's subjective.
Subjective.
Okay.
Okay. It's subjective. So you can't look at somebody and say they're hurting or they're not hurting. Okay. Because they might have a higher tolerance for the pain than somebody else. They may have a lower tolerance than somebody else. Okay. They may be from a different kind of culture and express their pain differently. Okay. So that's why you always have to use the numeric scale and ask the patient about their pain because it's subjective. Okay. So that's the reason why you have to ask a patient about their pain so they can tell you themselves. Okay.
I have
Does
a
that
question.
make
I'm
sense,
sorry.
Bridget? I'm sorry. Yes. Go ahead.
Okay, so when we using the face and the person can't talk, but their facial expression is saying something is wrong, so that wouldn't be right, or will it? Or
No, that would be right. You would use, and we're going to talk about this in a little while. There's a scale in the book called the Flack scale for patients that can't talk. Okay. are in debilitated of any particular kind, okay, you can use that Flax scale, okay, and it kind of gives you an overall look at their body and see, okay, are they grimacing? Are they tensing their muscles? Are they, it's different things that you can see, okay, that the patient may be telling you without being able to speak, okay. But for the most, but yeah, in those situations, then yeah, you would kind of have to, you would have to rely on your visual assessment skills, okay. But for the most part, for a good percentage of the time, okay, this question was mostly just to get your mind around the fact that pain is subjective, okay? So you can't automatically just think just because if a patient is not expressing pain, that they're not in pain. That was the point I was trying to get to with this class, with this question. However, yes, in those kind of situations, you would have to visually assess the person, okay? But yet, if the patient can't talk, that doesn't mean they can't write on a whiteboard, or that means that doesn't necessarily mean that they can't nod their head or shake their head, okay, and say yes or no if they're in pain, okay? So there's other ways, even if a patient is incapacitated and can't talk or something, to that extent, there are still other things that you can do to get the patient to assess the pain in the patient. Does that make sense, Opal?
It does. Thank you.
You're welcome. Okay. In the blank phase, neurons send signals to the spinal cord by release of neurotransmitters, transduction, modulation, perception, or transmission phase. Neurons send signals to the spinal cord by release of neurotransmitters. Okay, it's actually modulation, okay? So in modulation phase, okay, the pain has already been sent to the spinal cord, okay, because that was done in transmission, okay? So the signals are in the spinal cord, okay? They are already in the spinal cord, and the brain is going to release the neurotransmitters, okay? Neurotransmitters is going to be those little signals that's going to tell the body, hey, you're in pain, okay? And that's going to be modulation. Neurotransmitters can be not just telling the body that it's in pain, okay? But it also is going to help the body to defend against the pain by some way, either by releasing substances, okay, or, mostly by releasing substances, okay, those powerful substances that are going to help to kind of control the pain, okay. So neurotransmitters can either do one of two things, okay. They can tell the body, hey, you're in pain, or they can start defending the body from the pain, okay? And that happens in the modulation phase when these neurotransmitters come on board, modulation phase. Any questions there? Okay, so yeah, in transmission phase, the signals are sent to the spinal cord. Okay, that is true. Okay, in transmission phase, that is true. Okay, but in modulation phase is when these neurotransmitters come on board. Okay, so I always think modulation equals neurotransmitters. Any questions? Okay. All right, let's see. Who came out third? Let's see, Emily Watson, good job. Okay, Cheyenne came out second. And Bridget came out first. Good job, y'all. Good job. And Casey and Jordan came up runners up. Good job. Y'all did a good job. Okay. So let's see. Let's go back to that question. All right. Let's see. I want to go. Where do I want to go here? Okay. Hold on one second. Let's see. I want to go to the Kahoot. I'm going to go to that first question that you said could be select all that apply. And I don't want to do that. Hold on, guys. 1 second. Let me see. That. Oops. Hold on. Go back to my Kahoot. Go to that first question. We'll go over that first question and see. Okay. Oh, it's going to need to log in again. So we can kind of clarify that first question that y'all were talking about that had to select all that apply about the pain theory gate. Let's see. Let's see. Okay. So let's look at this one. Okay. So it says, what is the gate control theory of pain? Okay. And the answer was this. When the gate is open, the pain sensation is allowed through. Okay. Stimuli other than pain stays out of the gate. Not necessarily. Okay. That's not necessarily true, because if you have other stimuli that competes with the pain, okay, then that other stimuli can get through the gate as well. Okay.
I
If
just
you
read
give
the PowerPoint slide and I understand that I was wrong because on the PowerPoint it says stimuli other than the pain pass through the same gate. I just wasn't paying attention.
Okay, no, that's okay. I just wanted to make sure I clarified it for you.
Yes, ma'am.
Okay, all right, okay. Okay, so now we're gonna go to our PowerPoint. I'm gonna stop sharing. Okay, let's see, and share screen. I'm gonna go, oh, it's not there. Come on now. Okay, PowerPoint. Okay, hold on, pain reading. Let me just make sure I have my right one up. Let's see, I'm gonna go to slide 24. Okay, so 24. We stopped at pain threshold. Let me go back. Okay, I'm going to share my screen. And now we got our PowerPoint. Okay. All right, I'm going to go into okay, so we're still on chapter 7, still talking about pain, okay? So yesterday we left off at pain threshold, okay? Pain threshold, okay, is at the point at which pain is perceived, okay? So threshold is that point when the patient is going to perceive the pain, okay? Relaxation and distraction strategies can alter the perception of pain, okay? So some patients may have a high threshold for pain where it takes them a long time before their pain is perceived, okay? Or some patients may have a low threshold where it doesn't take a lot for them to perceive pain, okay? So, but just know too that relaxation and distraction strategies can alter the perception of pain. Okay, it all has to do, going back to that gate therapy, okay, that gate theory, okay? If you give that pain some competition, okay, with this relaxation and distraction, okay, it's gonna fight for that open gate. Okay, it's going to give that pain, that relaxation and distraction, is going to give that pain a run for its money. It's going to give it some competition. So it's when it gives the pain that competition, the pain kind of loses its power, okay? And it loses its efficiency, okay? So that's why we want to add on relaxation and distraction strategies. We want to give that pain some competition, okay? We don't want to make it easy for that pain to go through the door, okay? Chat up in case I don't want to miss any chats, okay? All right. Okay, let's see. Okay, next. Okay, so now we talked about pain threshold. Okay, so pain threshold is the point where a person perceives pain. Okay, pain tolerance. Okay, tolerance is going to be the length of time or the intensity of a pain a person will endure before outwardly responding to it. Okay, so going back to the other slide, pain threshold is when the patient perceives the pain. Pain tolerance is when they respond to the pain. Okay, so you have perception versus responding. Okay, again, a patient can have a high pain tolerance. They can go hours, maybe days, without responding to the pain, without taking any kind of pain medicine, without resting or anything, okay? Or they can have a low pain tolerance, and as soon as they feel a twinge of pain, they want to take every pain medicine that they can have, okay? So again, tolerance is responding, okay? And pain threshold is going to be perceiving. Is there any questions about that? No questions? Okay. Okay. So tolerance, pain tolerance, how a person responds to the pain, okay, it varies among people and is greatly influenced by culture, pain experiences, expectations, and role behaviors. Okay, so yes, different cultures may express pain in certain ways, and they may have higher or lower tolerances depending on their culture. But also, okay, culture, how one is raised, okay, by their whoever raised them, their parents, their grandparents, or family members, or whoever, okay, whoever raised that patient, that patient learns by seeing those people that were in their life most of their lives and how they responded to pain, okay? I know growing up, my mom and dad were very stoic. Well, my mom was very stoic as far as pain, okay? She didn't take any pain medicine. She didn't go to the doctor. You know, it was just kind of a shake it off type of attitude, okay? And that's how she taught us, okay? As kids, as me and my brothers and sisters, you just got to shake it off, okay? You got to shake it off and you got to deal with it, okay? That's how she taught us to learn how to deal with pain, okay? Now, I had a friend of mine, okay, who would just sniffle and her mom would keep her home from school, okay? Her mom wouldn't let her go to school. So it's two different types of pain tolerance that were learned, okay? So again, tolerance is influenced by culture, experience, expectations, and role behaviors, okay? Any questions or issues or comments here? Okay, next. Oops. Okay. Some physiologic responses to pain, okay? So physiologic response, okay, is going to be something physical in the body, how the body responds physically to pain, okay? So pain can cause a variety of physiologic responses, including increased respiratory rate, pulse or blood pressure, muscle tension, sweating, flushing or pallor, frowning, grimacing, or groaning. Okay, those are some physiologic responses to pain. Okay, so in this case, okay, yes, you could visually see that kind of stuff. You could visually assess this kind of stuff, but you would still want to ask the patient what their pain is if they can do so. Okay. And again, it says, although the presence of any of these factors may indicate pain, their absence does not prove the absence of pain. Okay. So just because they don't have increased respiratory rate, just because they don't have sweating, just because they may not be frowning, grimacing, or groaning, does not mean they're not in pain. Okay. Pain is subjective. You should always ask the patient about their pain. Okay. A lot of hospitals and facilities will, when you go through their orientation or whatever, will tell you pain is the 5th vital sign. Okay. So when you do vital signs on a patient, you should be asking them about their pain right after you do their vital signs. Okay, think of pain as the 5th vital sign. Okay. Let's see. No, I won't let me do the next one. Okay. All right. So cultural considerations, we talked about that. A person's cultural background influences feelings about pain. In much of Western culture, okay, it is considered valuable, okay, to have a high pain tolerance, particularly among men, okay? Other cultures promote the idea that to endure pain is natural or honorable, okay? Learning to accept without judgment the various ways of coping with and expressing pain is a very necessary process for nurses, okay? So you always want to take into consideration a patient's background, a patient's culture. Okay. Is it part of their culture to scream and holler and outwardly express their pain? Okay. That might be part of their culture to do that. So as a nurse, you have to be mindful of that. Okay. It's not that they're just screaming and hollering for the benefit of screaming and hollering. That may be how they express pain. Okay. All right, let's see. Older adult care points. Okay. The idea that pain perception diminishes with age is false. Okay. So just because a patient is old, okay, does not mean that their pain perception decreases. Okay. In fact, the perception of pain may actually increase with age as the individual becomes frail, has more than one chronic ailment, and has fewer resources for tolerating pain. Okay. And resources can be both physical and financial. Okay. They may not be able to afford their pain medication as they get older. Okay. Or a physiologic resource would be like having the subcutaneous fat around a particular area. Okay. So when they fall, okay, that fat kind of cushions the bones. Older people have less subcutaneous fat as they get older. Okay. So when older adults fall, okay, their risk of breaking a bone is higher because they don't have that padding, that subcutaneous fat, and as well also the muscle too as well that surrounds those bones. The muscle is really weak there. Okay, so that would be considered like a physiologic resource, that a decreasing physiologic resource for the patients. Okay. All right, next. All right, so now we're going to talk about 2 different kinds of pain, acute and chronic pain. Okay, and we're going to go over each facet. Duration, we're going to go over duration, prognosis for relief, cause, psychosocial effects, and effective therapy. Okay, so those are 5 different facets that we're going to go over: acute versus chronic pain. And yes, they'll be a little bit different. Okay. So acute pain, the duration of acute pain is going to be from hours to days. Okay. That's going to be the duration of acute pain. Okay. Chronic pain. Okay. You think of the word chronic. Okay. Chronic pain is going to be months to years. Okay. So think chronic. Chronic means a long time. Okay. So their pain is going to last longer. They're going to have a longer duration in chronic pain. Okay. Prognosis for relief. Okay, so prognosis for relief means how able is the advanced practitioner or the doctor going to be able to relieve their pain? Okay, how likely is it that the patient's going to get relief? Okay, in acute pain, okay, the prognosis for relief is good. Okay, in acute pain, it may resolve spontaneously or in response to analgesic therapy. Okay, so the prognosis for relief will be good in acute pain. In chronic pain, okay, the prognosis for relief is going to be poor. Okay, unless complicating factors are removed. Okay, or spontaneous relief is unusual. Okay, and in chronic pain, okay, an example of when complicating factors would be removed, okay, might be, okay, let's say a patient has pancreatitis and has been having pancreatitis for a long time, okay. Well, the complicating factor there would be the pancreas. So if the pancreas would be removed, okay, then the pain would be relieved, okay. So that's what it means when it says complicating factors removed. Okay. But just know most of the time, chronic pain, okay, chronic pain is going to be more neuropathic in nature. Yes, you can have nociceptive chronic pain. Okay. But for the most part, chronic pain is going to be neuropathic. Okay. Yeah. Neuropathic in nature. Okay. All right, any questions so far? Okay, all right, next. So now we're going to talk about the causes of acute pain and the causes of chronic pain, okay? Acute pain, the cause is going to be relatively easy to identify, okay? A good percentage of the time. In acute pain, it's going to be relatively easy to identify. In chronic pain, okay, sometimes the cause is known, but diagnosis may be complex or undetermined. Okay, so the cause in chronic pain a lot of the time is going to be hard to understand or hard to treat, or sometimes they may not know where it's coming from. Okay, in chronic pain. Okay, so that's the difference between the cause. Okay, in acute pain, it's relatively easy to identify. In chronic pain, sometimes it's known, but most of the time it's going to be unknown or complex and very hard to treat. Okay. Acute versus chronic pain, psychosocial effects. So what it does on the brain and what it does on the psyche. Okay, so in acute pain, what it does on the psyche, it's usually transient or none. Okay, so it may last a little while or it may not last at all. Okay, the psychosocial effects. It may temporarily disrupt normal activities or routine. Okay, so it's going to be in acute pain, it's normally going to be the psychosocial effects, okay, the depression, the anger, whatever psychosocial effects are going on with that particular patient, okay, are going to be temporary in acute pain. In chronic pain, so if it's temporary in chronic pain, if it's temporary in acute pain, it's going to be the opposite in chronic pain. Okay, it's going to be long term. Okay, the psychosocial effects are going to be long term. It can affect the ability to earn a living, enjoy social activities, and maintain self-esteem. Okay, so it's going to do a number on the psyche in chronic pain. Okay, and again, that makes sense. These patients are having this pain for a long time. Okay, they can't get rid of it. They may not know where it comes from. Okay, so that can really mess up a person's psyche. Okay, all right, and pain is not comfortable. Okay, pain is not a good thing. Okay, so it's a bad thing. So bad things are going to have an effect on the mind, okay, over time if it keeps going on and on, okay? All right, effective therapy. Okay, so how effective is therapy going to be in acute pain, and how effective is it going to be in chronic pain? Okay, in acute pain, okay, medication is usually beneficial. Surgery is often helpful. Okay, that's in acute pain. Okay, in chronic pain, medications may be helpful, but patients may become dependent. Okay, if their chronic pain is from a neuropathic source, is opioids going to help these patients? Mackenzie says no. That's right. Okay. So remember, opioids do not work on neuropathic pain. Okay. They only work on nociceptive pain. Okay. And like I said, a good amount of the time, the chronic pain is going to be neuropathic in nature. Okay. So opioids and painkillers a lot of times will not help these patients in chronic pain. Okay. They may be some pain medicines, okay, that may be helpful. Okay. But normally in chronic pain, if the medications are helpful initially, okay, the problem is they may become dependent on those meds, okay, and become addicted. Okay, so that's how the effective therapy is on the chronic pain. Okay, multiple medication regimens may be used. Okay, so not only they may be on different forms of pain medicine, or they may be on a neuropathy type of medicine such as gabapentin, okay? But they also may be on an antidepressant. They may be on a antiemetic, okay? So they won't normally just be on one particular medication for chronic pain. They'll normally be on a bunch of different medicines, okay? Surgery may help, okay? But it can also worsen the problem too. Okay, again, it may help initially unless the surgery gets rid of the organ causing the chronic pain. Okay, but it can also worsen the problem. So that's the difference between the effective therapy on acute pain and chronic pain. Any questions? Okay. I'm probably going to use these acute versus chronic pains in the form of either a select all that apply question or a not question, like which of these would not be an effective therapy on chronic pain. Okay, those are probably how I'm going to use those questions on the test. Okay, or how I'm going to take this content and put it on the test. Okay, all right, let's see. Okay, some older adult care points. Okay, so between 50 and 70% of the older and the adults in the community have chronic pain. Okay, again, that makes sense, right? Their body's breaking down. Okay, they don't have the physiologic resources in their body that they used to have. Okay, and that's going to cause newer and more chronic issues. Okay, the most common conditions causing the pain are joint problems from osteoarthritis, degenerative disc disease from osteoporosis, low back pain, and pain from previous fracture sites. Okay, those are the most common conditions in the older adult care. And it's as if their chronic pain is adequately controlled, the quality of life is improved, right? Okay, they get a better mindset. Okay, if they're not in pain 24/7. Okay, if their pain is managed 24/7. Okay, they'll have a better quality of life. Because like I said, pain's not a fun thing to deal with. Okay, it's not a positive thing. Okay, it doesn't make the patient feel good. Okay, so if all these things are happening to the patient, okay, the patient, a good percentage of the time, is going to have a depressed psyche. Okay, if their chronic pain is not managed properly. Okay, any questions? Okay, so let's go ahead and take a little 5-minute break. We'll come back and I will finish the rest of the slides on pain, and then we will do our bill the patient. So come back in 5 minutes. Okay, guys, we're gonna go ahead and get started back. Okay, so everybody hop back on. Okay. So now we're gonna go into, okay, with every disease process, okay, that we're gonna go over in PN1 and PN2 and PN3 from here on out, okay? We are going to go into the nursing process with each particular disease process, okay? Not that pain is necessarily a disease process, but it's a medical condition, okay? So I say disease process slash medical condition, okay? We're gonna go into the nursing process of how we are going to take care of these people, okay? And what's gonna be in our nursing process to take care of the patient with pain, okay? So we're gonna start off with the first step of the nursing process, which is assessment, okay? And let's see if you are following along in your book. Okay. We are on page 7, 6 or 7. Yeah. Okay. We're going to start on, we're going to start on page 128 in your book if you're following along. Okay. But the slides kind of give it, they kind of summarize it. So, I know some people like to follow along in the book, some people don't. Okay, but that's where we are. Okay, so some things you're going to want to assess. Okay, you're going to assess in a patient with pain. Okay, you're going to assess their appearance. Okay, how are they looking? Are they tense? Okay, are their shoulders slumped? Are they shoulders not slumped, but are they shoulders tense? Okay. They have a face like this, or they have a tense face. Okay. Are their muscles tense? Okay. Are they holding on to a particular part of their body and they're not letting go? Okay. Behavior. Okay. How are they behaving? Are they depressed? Are they angry? Are they sad? Okay. What's their behavior? Okay. Are they short and curt with you? Like when you ask them a question, they're like, yes, no, I don't know, leave me alone. Okay. That's behavior. Okay. Activity level. Okay. Activity level in the assessment phase is going to tell you, are they getting out of bed? Okay. Is their pain keeping them from getting out of bed? Is their pain keeping them from turning on their side? Okay, is their pain keeping them from sitting up in the bed? Okay, so we want to know how their pain is affecting their activity level. Okay, how are they verbalizing their pain? This is where your pain scale is going to come in to count. Okay, whether it be by the number, numerical pain, the 0 out of 10 scale, or the faces. Okay, the faces scale. Okay, because sometimes, like you guys and like me, sometimes patients are visual learners. They're visual people. Okay, and if you ask them 0 out of 10, with 10 being the worst pain, they're like, I don't know, because it's kind of like I don't know, it's not really the worst pain I've had in my life, but I don't know, I can't give it a number. Okay, if they tell you that, then you may want to show them the faces scale. Okay, and the faces scale is on page 130 in your book. Okay, and this is what it kind of looks like. Okay, all right, and you tell them to choose a face. Okay, choose a face that you feel like right now. Okay, this also works well with children too. Okay, to use in pediatrics. Okay, and sometimes they can rate their pain better using that. Okay. And physiologic clues, okay, is their blood pressure high? Okay, is their respiratory rate high? Okay, those are going to be some physiologic. Are they sweating profusely? Okay, are they pale in color? Do they have pallor? Okay, those are going to be some physiologic clues okay, that are going to clue you in to that the patient is not comfortable, okay, not comfortable at all, okay. Okay, any questions here? Feel free to stop me if I'm going too fast, okay, guys? All right, say Miss Adams, stop, go back, okay? Or just write in the chat, stop, go back, okay? You can do that as well, all right? Some older adult care points, okay? Y'all know I love those older adult care points in the book, okay? I love them for test questions. I love the clinical cues for test questions, and I love the safety alerts for test questions, okay? So make sure when you go through the book, make sure you go through those and you know them, okay? And you're familiar with them, okay? So in older adult care points, older patients may not report pain for a variety of reasons, and their pain is often undertreated. Okay. So some of the reasons why they think that they may not report their pain, okay, is because they think it's an expected part of aging. Okay. Oh, well, I'm just getting old, so my body's wearing out. So, I mean, it's just a normal thing for me to be in pain. Okay. Well, when you break your hip, that's not a normal thing. Okay. And that can be fixed. Okay. So, you know, that's not pain's not a normal thing. Okay. So some patients, some older adults think that because they're in pain, it's just because they're getting old. Okay. They may deny pain because it means they're getting older. They don't want to say that they're getting older. Okay. Because some people think that when they get older, they get weaker, okay? And they may not want to admit to that. So they may not want to say they're in pain because they don't want you as the young nurse to think that they're weak, okay? They may not report pain because they believe they cannot afford the cost or tests or treatments, okay? They're afraid that if they tell the doctor or the advanced practitioner or the nurse that they're in pain, okay, oh, well, this is going to cost me more money. They're going to put me through more tests and they're going to give me more medicines and this is going to cost me more money and I don't have that, okay? So that's another reason they may not report their pain, okay? Older people often say they have soreness or discomfort rather than pain, okay? So when they tell you these terms, as the nurse, you have to investigate. You'll investigate and you'll say, okay, well, on a scale of 1 to 10, with 10 being the worst pain you ever had in your life, okay, tell me what your soreness is like right now from that scale, okay? Or show them the faces. Say, okay, you're saying you have soreness, okay, but show me on this scale, you know, how your soreness is making you feel right now. Okay. So when these words are vague, okay. So when they say they have these things, okay, you want to investigate more into it. Okay. And again, assess further if such comments are made. Okay. Any questions? Okay. Next. Okay. So pain rating scales, okay, are very, very useful in pain evaluation and pain assessment. Okay, they are going to be your go-to for your pain assessment. Okay, pain rating scales. Okay. When using a pain rating scale, it is important that the nursing staff use it consistently and the patient fully understands how to use it. Okay, so when you're interviewing a patient, when you're assessing a patient's pain, okay, you just don't want to say, okay, what's your pain on a scale of 1 to 10? Okay, because they may think, okay, what does 1 mean I'm in a lot of pain, or does 10 mean I'm in a lot of pain? Okay, so you want to explain the scale to them. That's why I always say, with 10 being the worst pain you've ever had in your life, what number would you give your pain right now? Okay, give them a reference. Okay, and it says the type of scale being used and any pertinent information about how the patient uses the scale must be included in the patient care plan. Okay, so what scale you're using, okay, needs to be in your documentation. Okay, and it needs to be maybe given in report to the next nurse. Said, look, he doesn't know how to rate his pain on a numerical scale, so I used the FACES scale. Okay, so that nurse knows that when she goes in to go interview and assess that patient, she knows that she is going to use, okay, the FACES scale rather than the number scale. Okay. So let's see. So number scale we went over, okay, 0 to 10 or 0 to 5. I normally use 0 to 10. It seems like an easier thing to do, okay. It can be used effectively with people who have a good understanding of the numerical concept and who like a strictly logical approach, okay. It's not appropriate for young children. Anyone who has a difficulty with numbers, okay, so your learning disability patients may not do well with a numbered scale, okay, or anyone who's confused or disoriented, okay. So in that case, you would have to use a FACES scale, okay, or you may have to use your FLAX scale, okay, which we'll go over in a minute, okay. Visual scale, okay, that's going to be your FACES scale, okay. Color scale, I've never really used this one, but you could use different colors, like blue means you're in a lot of pain, yellow means you're in no pain, okay. Red means you're in the middle of the pain, or, similar, but I've never used a color scale. I've either used a number scale or a FACES scale in the 21 years I've been practicing, okay? And it says this scale is often used with children, but very young children cannot understand more than 3 or 4 possible choices, okay? So you want to, when you're in pediatrics, you want to make sure that you keep it as simple and low number as possible, okay? Pieces of pain. Again, this is just another scale. I've never used this, but it says use 5 poker chips or other identical plain objects that represent pieces of pain. It says the patient indicates the degree of pain by selecting the number of chips that equals the intensity of pain being experienced. Okay. So again, it might be good for those tactile people that they need to put their hands on it, okay, to show you their pain. Okay, so you could either say, okay, here's some pencils, okay, tell me out of these pencils, how much is your pain? Is it 4 pencils? Is it 5 pencils? Is it 2 pencils? Is it 1 pencil? Okay, so that would be an example of a pieces of pain scale. But again, I've rarely used this in practice, okay, but it might be good for somebody that cannot verbalize numbers or is having a hard time deciding which face they are, okay. So it's just another alternative. Okay, FLAX scale. Okay, this is on page, let's see, page 130 in your book, okay. You're going to use the behavioral or FLAX scale, okay, with patients who are cognitively impaired or cannot speak. Okay, so these are going to be your patients that are paralyzed, that can't talk, okay, that may be blind, okay. So these are going to be, this scale is going to be used with these patients, okay. The nurse assesses the patient's behavior in categories such as facial expression, limb movement, and activity level, okay. And a score from 0 to 2 is obtained for each category, and the category scores are added together to arrive at a pain score total of 0 to 10. It is useful when assessing the pain of confused or nonverbal adults, infants, and young children. Okay, babies, like infants, neonates. Okay, you can use the FLAX scale. And again, that's on page 130. Okay, like I said, it gives different you know, like, okay, one of the items, okay, so it's called FLAC because it assesses the face, the legs, the activity, the crying, and the consolability. Okay. Can a patient be consoled? Okay. You'll get, if the patient can be consoled, they'll get a 0. Okay. If they are somewhat consoled, okay, they'll get a 1. Okay. And if you cannot console them or are they difficult to console, they'll get a 2. Okay. So know this scale, know what's involved. Okay. Because the question that I might give you on the test, okay, I'll give you a scenario. I'll say you have a patient that is, okay, kicking up their legs, is moaning and whimpering, and is difficult to console. Okay. What number on the FLAC scale would you give them? Okay. So if you look at your FLAC scale, okay, well, I'd actually have to give you something with faces too. So let's say I'd say that, okay, the patient is frequently clenching their jaw. Okay. They're kicking their legs. They're squirming back and forth and are tense. Okay. They moan or whimper, and they are difficult to console. Okay, so that would be a 2 for face, that would be a 1 for legs, a 1 for activity, a 1 for cry, and a 2 for consolability. So that would be 2, 3, 4, 5, 7. Okay, so that would be a FLAC score of 7. So I would tell you, I'd give you different FLAC scores. Okay, is it a FLAC score of 7? Is it a FLAC score of 2? Is it a FLAC score of 9? Or is it a FLAC score of 0? Okay, and you'll have to choose which FLAC score based on the scenario that I've given you. Okay, all right. So that's how that's going to be in the form of a question. Okay. Ashlyn says 8. Okay. Yeah, I guess let's see. 2, 3, 4. And if it's a moan or whimper, that would be 5. And if it's difficult to console, that's a 2. So that actually would be a 7, Ashlyn. Okay. For that, from based on the scenario that I just gave you. Okay. Any questions there? Okay. Older adult care points. Okay. A more accurate assessment of a pain in older adults is obtained when several types of pain scales are used, such as a number scale, a visual scale, and a behavior scale. Okay. So you may need to use several types with an older adult care. Okay. It says, Ashlyn says, so you can use faces and FLAC for children. Yes, they're actually recommended. Okay, that you use faces and FLAC scale for children. Okay, especially younger children. Okay. Okay. Let's see. So this is your face paint, your faces. Okay. This is your FLAC scale. Okay, so know this FLAC scale. Okay, know which, what number goes with what item, or what number goes with what symptom. Okay, so you can be able to recognize what that FLAC scale would be. Okay. Data collection difficulties in pain. Language barriers is huge if your patient doesn't speak English. So will you give us the scale on the exam? I'll tell you the number in the question. So for the test, do we need to memorize the entire chart? Yeah, you want to know what sign goes with what number. Okay. I'll tell you in the answers, I'll give you multiple choice of which scale it would be. Would it be a FLAC scale of 6? Would it be a flat scale of 8? Would it be a flat scale of 1, or whether it be a flat scale of 9? Okay, so you need to know what symptoms go with what number. Did that answer your question, Mackenzie and Ashlyn? Yes, okay, all right. Okay, so cultural considerations, pain expression and meanings, preferences and actions, okay, can also be difficult assessing a patient with pain. Referred pain and heart pain, okay, is another difficulty. Okay, referred pain means that, like chest pain, okay, chest pain is a good example. Okay, sometimes chest pain refers to the arm, like it goes to the arm. Okay, so even though the patient says, I have really bad arm pain, okay, but it might be coming from their chest. Okay, so that can be a difficult, even though the patient says my arm is super hurting, okay, but it might be coming from the chest. Okay, that's an example of a referred pain. Okay, so sometimes those situations can make assessment difficult. Okay, so you may have to, in that case, that when you have those data collection difficulties, okay, you may need to do some investigating. Okay, you may need to do other forms of assessment. You may need to take their vital signs. You may need to run some labs on them. You may need to listen to their heart sounds. Okay, you may need to do a little bit more digging, okay, before you call the advanced practitioner or the doctor and tell them that the patient's having chest pain. Okay, all right, so little few things that are going to make it a little difficult to assess pain. Okay, all right, so we're going to skip this one. Okay, so planning. Okay, planning or goals, okay, in the patient with pain. Okay, so overall goal, of course, relief of pain. Okay, you're going to indicate actions that promote comfort. You're going to offer a team approach. Okay, so you're going to get the advanced practitioner on board. Okay, you may need to consult a pain specialist. Okay, whether that be a nurse practitioner, a nurse, or a doctor. Okay, you may need to get a psychiatrist on board as well. Okay, for a patient to plan to get a good plan for a patient with pain. Okay, you are going to think about your non-pharmacologic and your pharmacologic interventions. Okay, so you're not just going to throw medicine at them. Okay, you may want to do some non-pharmacologic techniques. Okay, like I said, such as massage, heat, cold, meditation, breathing, distraction. Okay, those are all non-pharmacologic interventions. Okay, you're going to consider the type of you're going to plan for the type of medication, method of delivery, and comfort measures. Okay, so if you are going to give this patient medication, which 95% of the time you will, okay, you're going to want to think about what medication is going to work the fastest. Okay, out of an IV medication, an oral medicine, or a IM medication, which one of those is going to work the fastest?
IV.
IV. Okay, IV is going to work the fastest. Okay, so depending on how severe the pain is and how quickly you want to get a pain medicine on board, okay, is going to depend on which medication route that you're going to take. If a patient is in severe pain and rating their pain 10 out of 10, okay, and their blood pressure is through the roof, okay, you're not going to give them a PO pain medicine. Okay, you're going to go for the IV stuff. You want that pain under control. You want those vital signs to start to come down a little bit. Okay, so you want that IV pain medicine on board if their pain is that severe. Okay. Now, if a patient is maybe rating they're maybe like 5 days post-op, okay, and they're rating their pain a 6 out of a 10, but they're going to therapy, so they know they're going to hurt after therapy, okay, then you may want to give those patients a PO medicine, okay, because they're not really hurting that much right now, but they will hurt after therapy. So we want to get a little bit of pain medicine on board before therapy so that they can do their therapy and they won't be so in pain so bad after therapy. Okay. All right. So that's some things that you would do in the planning phase. Okay. Plan what medicines you're going to give them, the non-pharmacologic interventions, the different team members on board. Okay. These are things that you'll do in the planning phase. Okay. Implementation, reassess, 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 reassess. Okay. If you give a patient a pain medicine, you always want to document, okay, somewhere in the chart, in the physical chart, wherever, okay, you want to reassess that pain in 30 minutes, a minimum, okay, of 30 minutes. Okay. On page 133 in your book in clinical cues, okay, it tells you how long it takes medications to be effective. It says medications given by the mouth may take 30 to 45 minutes to be effective. Injections like sub-Q or IM injections are effective within 30 to 45 minutes, and IV medications are effective within 5 to 15 minutes. Okay, so depending on what route you gave that medication, okay, you need to be going back and reassessing that patient's pain. Okay, and again, that's on page 133 in the clinical cues. So you may want to know that. Okay, that's pretty important. Okay. Implementation, appropriate interventions. What interventions are you going to do? Are you going to give them pain medicine? Okay. Are you going to reposition them? Okay. Are you going to apply heat? Are you going to apply cold? Okay. Are you going to use a distraction technique? Okay. So those interventions are going to go under implementation. Okay. But they have to apply to the situation and the patient at hand. Okay. You're not going to put and implement, if a patient is blind, okay, you're not going to write in your implementation, we'll have patient watch TV. He's blind. He can't watch TV. Okay. So again, you have to relate it to the patient. Okay. Or if a patient, if you have a baby for a patient, okay, implement meditation strategies for patient. A baby doesn't know how to meditate yet. Okay. So that wouldn't work. Okay. So you want to make sure that your implementations go along with your patient at hand. Okay. It's implementations that your patient will most likely be able to do. Okay. Teaching is going to be another implementation. Okay. You're going to teach your patients about their pain medicine. You're going to teach them about different distraction techniques to do in between their pain medicine. Okay. And why you're doing that. Okay. Why you're telling them to, take some deep breathing, or why you're telling them to watch TV. Okay. Because that's going to distract them and it's going to compete with that pain, and it's going to decrease the power of that pain. That's why we're doing it. Okay. So you may have to teach your patients about this. Okay. And you're going to prevent complications from medications. What is a huge complication of narcotics?
Aren't you not supposed to drive if you're taking narcotics?
Yeah, but yes, that's true, but something a little bit more serious.
Addiction?
Addiction, yes. More serious than addiction. Think coding. think ABCs.
Is it respiratory depression?
Yep. Respiratory depression. Okay. Respiratory depression is huge in opioids and pain medicines. Okay. So that's the number one thing you want to look for when you give a patient an opioid. Okay. Or any kind of pain medicine. You want to make sure their breathing rate is within normal limits. Okay. Ashlyn said OD. Abigail said for kids, would you tell the parents too? Yes, absolutely. Okay, you would do some teaching with the kids, with the parents as well. Okay, and you would teach them about the pain scales, and you would teach them about the different pain techniques that you're using. So yeah, absolutely. Because the parents are going to be reinforcers, right? They're going to help reinforce your plan of care for their child. Okay, so absolutely. Okay. All right, next. To prevent complications, we're still in our implementation phase, okay? You're going to prominent documentation of any known drug allergies. Look for drug allergies, okay? So if a patient's allergic to codeine, okay, you're not going to give them something with codeine in it, okay? You're not going to give them oxycodone, okay? You're going to call that doctor and you're going to tell them, look, the patient, you may not have seen this, but the patient's allergic to codeine. Okay, so you definitely want to note your drug allergies, know your drug allergies. Okay, know your patient's drug allergies. Okay, actual recording of pertinent information obtained during the initial assessment phase, such as current medications, previous experience with pain, analgesics, and adjuncts to pain relief. A lot of stuff. Okay, a lot of words there. Okay, so again, to prevent complications, you want to do a good assessment. Okay, you want to find out, have you ever taken this drug before? Okay, if you've taken it, did something bad happen to you? Yeah, I got a little sick. Okay, or oh no, I can't take that because the last time I took that, they took me to the emergency room and I was on a breathing machine for 3 days. Okay, so you want to ask them these questions about this at any time you give any kind of medicine. Okay, you want to ask the patient, have you taken this before? Okay, especially if it's a new medicine. If it's a new medicine, or if it's a medication a patient hasn't taken in a while. Okay, you want to ask the patient about the medication, if they've ever taken it, if they've ever had any experience with it. Okay. Patient and family teaching regarding dose, frequency, and the need to consult with a physician or nurse before taking any other medications to avoid dangerous interactions. Okay, so you definitely want to, make sure you teach the family about the kind of medication and the patient and the family, the kind of medication that you're giving them. Okay, all right, so definitely. Okay. All right, let's see. Appropriate monitoring of effects of any medications given, okay, and prompt notification to the physician or advanced practitioner if medications fail to relieve pain or should problems occur, okay, because sometimes the doctor will order just one pain medicine. And over the last couple of years, doctors have been really, kind of not sketchy, but reluctant, okay, to prescribe pain medicine than they used to be. Okay, so they'll normally start off really small, okay, all right, with a pain medicine. Okay, a good percentage of the time, the doctors or the advanced practitioners will start off small, okay, with a small dose. And then they'll gradually increase the dose, okay? But if that small dose isn't touching that patient, okay, isn't letting that patient, isn't touching or isn't helping that patient, then we need to get another medication on board, okay? It's not doing the trick and it's actually causing more harm than good at this point, okay? So you want to be able, you want to call your advanced practitioners, okay? And you want to make sure that they know what's going on with the patient pain wise, okay? It says accurate and complete documentation of any adverse reactions to the treatment and communication of that information to everybody, healthcare providers, patient, and to appropriate family members. So that patient can know in the future, look, if this is ever ordered for you again, remember this medicine and tell the people that you can't take that, okay? So always communication is key. Document, document, document. If you didn't document, it didn't happen. Okay. Golden rule in nursing. Okay. If it wasn't documented, it didn't happen. Okay. All right. Let's see. Okay. Hold on. I'll go to the next slide. Which one is it? Evaluation. Okay, so you're going to assess before and after interventions, okay, depending on the route that you gave, whether it be PO, IV, or IM, you're going to assess before and after interventions, okay? And then these are some time frames, okay? Oral medications may take 60 minutes, okay? Injections are in about 30. I would hear from this slide, I would go by what the book says. Don't go from what this slide says as far as the effectiveness of the medicines. We'll go by what the book says on page 133 for test purposes, okay? All right. IV medications are going to be faster than that, okay? Documentation. You want to document your patient's pain. You want to document what you did for it. You want to document any aggravating factors and any alleviating factors. Okay. So document, document, document. Okay. Measures taken, what you did for the pain. Did you give them analgesic? Did you do adjunctive measures? Did you do heat? Did you do cold? Did you do distraction? Okay. Evaluation of the effectiveness of the measures. Were they effective? Did the patient meet the goal? Did they not meet the goal? Okay. Physician or advanced practitioner notified of problems or concerns, and any kind of related patient or family education. You want to definitely document. Okay. Great. Effective pain management is not just a matter of giving the right medication at the right time. Okay. So it's not just about one medication. Okay. It might be about a bunch of medications given at different times or even different days. Okay. It's about bringing in those non-pharmacologic approaches as well. Okay. Such as distraction, heat, repositioning. Okay, so it's about those. It's also about those non-pharmacologic approaches in managing pain as well. Okay, so it's not just about the medicine. Okay, yes, the medication is going to be effective. Okay, but it's only going to be effective for so long. So we got to get other things involved. Okay, other measures involved. Okay, to give that pain some competition. Okay. And decrease the power of that pain so that pain can't easily get through the gate. It's going to need some competition. Okay. All right. Let's see. Gesic ladder. We're not going to do that. Here are some pharmacologic approaches. We're not going to go too much into this because you'll get a lot of this in pharmacology. Okay. But these are just some examples of some medication pharmacologic approaches, oral analgesics, IM analgesics, subcutaneous, topical, transdermal patches. Okay, fentanyl patches are going to be your most common example of that. And buccal swabs, okay, that you swab on the inside of the cheek for pain medicine. Okay, I don't see a whole lot of these. I don't see a whole lot of buccal swabs, but that's what they're for. Okay. IV analgesics, patient-controlled analgesia, PCA pumps, okay? This is when the patient can control how much medication they're getting, okay? And they don't have to constantly ask the nurse for pain medicine, okay? When they're feeling pain, they press the button and the machine gives them the medication. Of course, the machine is set with parameters so that the patient doesn't overdose, okay? But this is a huge one, okay? Patient-controlled analgesia, epidural analgesics, okay? So sometimes patients that have back pain, okay, they'll give them epidural analgesics. They'll give them epidurals a couple of months to help with the pain, okay? And a peripheral nerve catheter is another pharmacologic approach, okay, where they're put in an actual catheter in the peripheral nerve where the patient is hurting, okay, and they'll have medicine that goes through that peripheral nerve catheter to help with relieve the pain, okay. Just a couple of pharmacologic approaches. Okay, let's see. Next. Okay, non-analgesics medications used for pain control. Okay, so these are going to be some non-pain medicines that are used in conjunction, that may also be used in conjunction with the pain medicines to control the pain. Okay, antidepressants, chemotherapeutic agents, and immunosuppressants, okay, can sometimes be used to help in pain control. Okay, anticonvulsants, muscle relaxants, and marijuana. Okay, marijuana is a huge, thing now. Okay, or they have all those little CBD oils and that sort of thing. Those CBD clinics and those CBD stores. Okay, that's a big thing now. Okay, some people are strictly just using the CBD oils for pain and not using any pain medicines at all. Okay, and CBD clinics and CBD stores and CBD oils came to the forefront because there was a huge opioid crisis here. Okay, and they were trying to relieve that opioid crisis. So that's why those clinics and the legalization of marijuana in some states, okay, became a thing, okay, to stop the opioid crisis that was killing the United States. Okay, so these are some non-analgesics medications that we're using for pain control. Any questions here? Okay, let's see next. I'm going to do one more slide and then we're going to stop. Okay. Well, I'm going to go over the clinical stuff for tomorrow and Friday. Okay. So special considerations in pain management. Okay. And again, this is one of those safety alert boxes in your book. Okay. So a lot of pain medicines contain aspirin. Okay. Contain a little bit of aspirin. So aspirin is a natural anticoagulant. Okay, what's an anticoagulant?
Blood thinner.
A blood thinner. Okay, so if you have too much aspirin in your blood because you take aspirin in a lot of your pain medicines, okay, a complication can be bleeding, okay, or excessive bleeding, okay, or low H&H's, okay, losing blood through the bleeding. Okay, so you have to be careful with assessing and taking care of patients that are taking a lot of aspirin containing products. Okay, because it can cause bleeding, excessive bleeding, and the patient to bleed out. Okay. Another one is acetaminophen and liver toxicity. Okay, acetaminophen is another word for Tylenol, right? Okay. Tylenol, if given too often and in exceeding doses, can cause liver toxicity. okay, in one of the safety alerts on page 135, okay, it says the recommended safe dosage of Tylenol is 4,000 milligrams per day. Okay, that is the highest point that you can go. That is the highest number of milligrams that you can give a patient, okay, to not make them liver toxic. Okay, 4,000 milligrams per day. Know that. That's very, very important. If it goes over that, you will give the patient liver toxicity and you may even destroy their liver altogether. Okay. Okay. Any questions on anything that I have talked about today? Okay. Okay. So now I'm going to go over your clinical assignments for tomorrow. Okay. So you are going to go into your clinical tile, okay, your nursing 2211 clinical tile, okay, and you have the following things to do on tomorrow, okay, you have 3 things to do on Thursday, tomorrow, and you have 2 things to do on Friday, okay. You will do your HIPAA skills module on tomorrow, okay, and an acid base and fluid volume video case study, okay. The HIPAA module should take you about an hour to do, okay. I have opened up the clinical tiles. I've opened up the assignments as early as 7 a.m., okay, and I left them open until midnight tomorrow night. They are due at 12 noon. Okay, so you need to have them done by 12 noon. That's the due date. However, I know people have computer issues and that sort of thing. So I've opened them until midnight tomorrow night. Okay, but the HIPAA module should not take you any more to do than an hour. Okay, so you're going to take that module. Okay, you're going to take the test. Okay, and then you're going to get, and then I will go back and look, and you have to, oh, and also on that HIPAA test, you have to score at least a 75% to be able to get credit for the assignment. Okay. And you can take that test as many times as you need to get to the 75%. Okay. So then I'll go back in, I'll go check in ATI, see who got the 75%, and give them the and put your clinical grade in for that assignment. Okay, for the HIPAA assignment. The acid base videos, the acid base and the fluid volume video case study should take you about a half an hour to do. Okay, so again, that comes with a test at the end. You can take the test as many times as you want to. You got to score 75% to get credit for the assignment. Okay, so it doesn't matter. Well, it matters that you have to get a 75%. Okay, but if you get a 75 or you get an 80% or you get a 90% or you get a 95, it's not going to, you're not going to lose points for if you get a 75 versus a 95. Okay, you just have to get a 75 on the test to be able to get credit for the assignment. Does that make sense? Okay. Okay. So that's going to be your modules to do for tomorrow from 8 a.m. to 12 noon. Okay. Like I said, they're going to be due at 12 noon, but I'm going to leave them open until midnight. Okay. The skills, the clinical stuff for Friday, okay, is going to be on ATI as well. Okay. So you're going to have, in Achieve, and again, I've outlined these directions like step by step, and they're in ATI, they're in Canvas. The directions for each module is in Canvas, okay? but I'll go over. Okay, you're going to have preparing for the clinical experience. Okay, that's going to be in your Achieve your Achieve tab in ATI. Okay, so you remember how we did the test taking strategies in ATI the other day? This preparing for clinical experience is going to be in that same tile in ATI. It's going to be in that same tab. Okay, it's going to be in the Achieve tab. So you're going to do that module. Okay, you're going to do that preparing for clinical experience module. You're going to take the test. Got to score 75% on that test to get credit for the class. Let's see, Marissa says, do the assignments on Canvas. So do the assignments on Canvas and the test on ATI. No, you're going to do everything in ATI. The directions are just going to be in Canvas. If you need to like specifically know how to get into how to get into ATI and what you need to do, okay, that's what you're going to need to refer back to. Okay, so everything is going to be done in ATI, but your directions are going to be in Canvas. Okay, Emily Watson, for the case study, do we do the test for that as well? Yes. Okay, got to score 75% on the case studies as well, on the test. Did that answer your question, Emily? Okay, all right. Okay, so Friday you do the preparing for clinical experience and Achieve. Okay, you take the test, you get a 75% to get credit for the assignment. Okay, then you will also do the physical assessment of the adult skills module. Okay, so you'll do that physical assessment module in the skills module. You're going to take the test, score 75 to get credit. Okay, so that's what you're going to do. The clinical experience, the preparing for clinical experience is going to take you about 30 minutes to an hour. The physical assessment will probably take you about an hour and a half to go through each of the modules and to go through each of the items in the module and take the test. Okay. And like I said, on these tests, you can take them as many times as you want to. Okay, you can take them, if you're not satisfied with your score initially, you can go back and you can take it. Okay, so you just need to get a 75 on the test after each module. Okay. Any questions? Are the directions already posted in Canvas for us to refer back to? Yes, they are in Canvas. Any questions? Okay, and I'll be here. I'll be doing work. I'll be doing school work tomorrow and Friday. Okay, so if you guys just email me, let me know. I'll have my email on full time. So if you have any issues or any problems, feel free to email me. Okay, with any questions or any concerns that you might have. All right, if that's it, we're going to end for today. And we will be back online on Monday. Okay, Monday hopefully will be our last day of online learning. Okay, because Tuesday will be our test and we'll be on campus. So I will see you guys back online on Monday. You guys have a great weekend. Have a great next 2 days. And again, feel free to reach out if you have any questions or concerns. Okay, but everybody's free to go now if you want to. I'll stay on if any of you have any extra questions.
Okay, so we were told that we go back to campus on Monday to take our test.
Oh, really?
For Miss Trailer, we've been like prepared to go on Monday.
I didn't think we could go back till Tuesday. I'm gonna have to talk to Miss Trailer about that. I didn't think we could go back till Tuesday.
Can y'all just email us when y'all find out, like either way?
We will.
Okay,
We
thank
will.
you.
You're welcome. Okay. Okay, Abigail. I don't know why I want to call you
Miss
Abby.
Adams,
Yes.
I know this is going to be a crazy question, but where do I go to find the directions for the?
Okay, you're going to go to the clinical tile in Canvas. You're going to go to the 2211 clinical tile first. Not the lecture tile, but the other tile. Do you see it, Jordan? No?
I'm going to figure it out. And if I
Okay.
don't figure it out,
Please let me know. Okay, if you can't get access to it or something for some reason, I don't know why, but please let me know. Okay.
I will. Thank
But
you.
everything's in the clinical tile on there. So
Okay, thank you.
okay, you're welcome. Okay. Abigail, what is your question, dear?
Okay, so first off, you can call me Abby if that's what you want. It doesn't bother me.
No, I'm a
But-
nickname person.
Yeah, it's fine. Like I completely understand. But okay, so I know my last semester we had to submit paperwork for any medications that we're on in case we get like drug screened.
Mhm.
I recently just changed medications, so like I take Xanax now.
Okay.
And like, will I be flagged for that, or should I get my doctor to write a note for that? Because like, I don't know what to do.
Just to be on the safe side, Abby, I would get your doctor to write a note for it.
Okay,
Say
that's
that
what
I
I
have
thought
prescribed
too.
this medication for my patient because of XYZ.
Right,
Just to
that's
be
what
on
I
the safe side.
thought, but I was like, I don't know if they still need proof of that for anything. But yeah, I was wondering about that yesterday, and I was like, ooh, I don't know who to ask about that.
Yeah, I would until they ask for it, like I would just have it on hand so that if that situation should come up, you have that on file, you have that documentation saying that you have a note from your doctor and it's saying that you're on this medication.
Right, because the last thing I want to be is flagged for drugs, you know?
No, absolutely. Absolutely.
Okay.
So I would have it on hand to have that documentation.
Gotcha. Okay, I'll go ahead and get that. Thank you so much.
You're welcome. No problem. What you got, Jordan?
Miss Adams, I found it. I don't know why I understand what you meant.
Okay. Okay.
I'm
So you
sorry.
have the clinical tile.
Yeah.
Okay. So you're going to go into each module. Okay. So each module has directions on how to do each module.
Yes, I wasn't thinking, I was looking at our PN class, not the PN clinical. I'm so sorry.
That's okay. No
But
problem.
thank you.
Rather you know. Okay. No problem. All right. Y'all have a good one. Ashlyn, you had a question? Ashlyn, do you have a question? Okay, I'm going to end the call. If you have any questions, let me know.